And, yeah, I think that's about it. You don't need to give me that address or just signature.
Okay. Just right here?
Yeah.
Thank you. I know.
Yeah, really. This shows true dedication to our speaker, the fact that we're not eating food and getting massages. We always need a massage. What I need is like something that just move the eyeball.
Should I come sit down until you're ready to go?
Whatever you want, you can sit up there. Chair, you can pull it around.
Hold it over here for now.
Get my Twitter feed set up.
This is being tweeted?
Well, so we now stream our conferences, and we have people ask questions via Twitter.
That's really cool. So students...
Anyone, our distance student, or really anyone in the world. The first one we did, we had like 50 people. It's tapered off a little bit since then. But there was a former student of ours from Saudi Arabia who happened to be in South Korea who tweeted a question. So it's kind of fun. It's search.
I was hoping I'd be able to see the upcoming slide on the machine, but it doesn't look like that's how it's set up.
Oh, because you're using
I think it's just a
Windows
mirror.
version. Yeah.
Yeah.
Well, that's the difference between like the Windows version and the Mac.
Yeah.
Yeah, I didn't flip through your slides. I just started it on the first, so I don't know what's coming. But
Yeah, we'll see if I do.
it's okay. I mean, sometimes there's layout weirdnesses between going.
Oh, yeah.
Usually it's not a
Yeah.
major deal.
You ready?
Yeah.
Yeah, but it's most powerful.
Well, welcome everyone. I want to welcome you all to our weekly research conference, which is at a slightly different time this week, because we have a guest from out of town who most of you know is an applicant for our faculty position. So Nicole Weiskopf is going to talk to us today on her research interest, which is of interest to a number of us as well, on the use of clinical data for clinical research. So Nicole is currently a PhD student in the biomedical informatics program at Columbia. She's an NLM fellow, so some of you in the room are NLM fellows, and may actually remember her talk from last year's NLM trainees meeting that won an award for the best talk. Prior to Columbia, she received a BA in psychology from Wesleyan University, and then spent several years conducting eating disorder research and schizophrenia research before transitioning into informatics. She's currently a PhD candidate. She's going to tell us a little bit about the research she's pursuing in her dissertation that focuses on methods to improve the efficiency and quality of clinical research. Her dissertation research addresses the problem of data quality as it relates to the reuse of electronic health record data in observational research. As we do now with all of our conferences, we are streaming this live, so there may be any number of people out there in the world who are listening to this. And should you have any comments or questions, you should tweet them to our Twitter tag at OHSU Informatics. If we ask that you put the hashtag DMICEConf, DMICECNOF, but we'll actually monitor the whole stream. And so if people want to ask questions that way, we can. And then, like all talks, we will post this to our website. So I'm going to turn it over to Nicole.
Thank you. Good afternoon, everyone. Can everyone hear me? Okay, great. Well, thank you for having me here. So today I'm going to be discussing some of the research that I've been doing as part of my dissertation on enabling the reuse of electronic health record data through data quality assessment. So to start with, I wanted to give a little bit of background about myself and how I ended up in informatics. So my original plan was to pursue a degree in research psychology. So my first position out of undergrad was at a center called KMH up in Toronto. I was with a concurrent eating disorder and addiction clinic. And I was very excited when I got there because their plan was to digitize all of their past diagnostic and clinical assessments. And then we were going to do retrospective research on this newly digitized data. And what my position ended up being was basically taking about 10 of these filing cabinets full of clinical diagnostics and trying to dump them into their brand new MS Access database. And I started doing this, and I quickly realized a couple of problems. One thing was the Access database was set up, for example, to want a specific age of onset for certain diagnoses or symptoms. And instead, because the actual assessments were for clinical purposes, they would say something like onset was during grade school. It was very young. And I would end up going down the hall and tracking down the original clinician and trying to nail them down on a specific age. There were also problems with data entry where they would only want a certain kind of diagnosis. Like there was only space to input one personality disorder. If you're familiar with this clinical population, they usually have multiple personality disorders. So what I ended up doing instead was building an entirely new MS Access database from scratch that addressed at least some of these problems. And we ended up being able to do a little bit of research at the very end, but mostly that was my entire time there. And after that, I moved on to schizophrenia research, where I spent 2 years. And when I got there, they had just implemented a much more robust database. And they would take all these different demographics, all these different assessments, electrophysiology, behavioral tasks, and put them into this database. And my job was to kind of maintain that and then to extract data sets for research after the fact. It was a really cool project. And I ended up getting more and more interested in the actual research issues instead of the psychology issues. So what could they do to improve their workflow? What could be automated? What were some of the problems with the system? And the fact that the database wasn't really set up to grow as the research itself expanded. So along the way, I realized what I really wanted to do was informatics. And I ended up going to Columbia University largely because I wanted to work with Dr. Chunhua Wang, who was specializing in clinical research informatics. I was also fortunate enough to end up working with Drs. Bach and Hripsack and Wilcox. And originally, I was going to look at electronic data capture systems, and Chunhua really encouraged me to look at the reuse of EHR data. And just this transition from paper records to electronic records, the current technology and existing models of success have put us in a better position today than we have been in before to realize the promises of health information technology to advance research. This is from a Weiner and MB editorial. And I think that it's pretty obvious why there are advantages to being able to reuse existing clinical data. Decreased cost, increased efficiency, and this happens at every stage in the research process. At the recruitment point, the retention point, and also the data collection point. There's also the fact that we often have an incredibly large volume of data when we're talking about clinical data. At Columbia, we have approximately 4 million unique patient records, which is pretty significant comparing that to a randomized controlled trial. And there's also the fact that we have a representative patient population. One of the criticisms of traditional research is that you have these very strict eligibility criteria, and a lot of the times the patients that you're recruiting are not representative of the patients that you're actually going to be treating. When you're using clinical data, you know that you have actual patients, they're in actual care settings. That is potentially a major advantage, especially if you're talking about something like patient-centered outcomes research or comparative effectiveness research. This inevitably led to the next question, though. Are electronic health record data of sufficient quality to be used in clinical research? So there's all this promise, but we know that there are problems with the data. And if you talk to people who are clinical trialists, they'll talk about an error rate of maybe like 2 out of every 1,000 pieces of data are incorrect or have some kind of problem. If you talk to clinicians, you don't know exactly what that error rate is, but you know that it's a lot higher. So to begin tackling this problem, I first looked at how people were already approaching EHR data quality. I started looking at the literature. And I quickly discovered a couple of problems. First, everybody talks about it differently. There's no accepted terminology. There's no standard model. And this is interesting because in other fields, there are very well accepted models. This is the Wang and Strong model. Outside of informatics, almost everybody at least talks about this, even if they're not actually using it. It's very well validated. And it doesn't get used in informatics. Recently, people are starting to talk about it, but at the time, not really. Everybody measures data quality differently. Most approaches to this are completely ad hoc. There's no systematic approach. So everybody's doing something different. And therefore, unsurprisingly, everybody actually gets different results in their data quality findings. These are pulled from 2 literature reviews on EHR data quality. The top one is the Hogan and Wagner review that a lot of people reference. So you see a huge range of correctness between 44 and 100%, huge range in completeness. And very interestingly, the Chan et al. Paper looked at different clinical variables, different phenomena. So specifically for blood pressure, there's a completeness ranging from just about 0% to over 50%. So that's one type of clinical variable. So what I realized pretty quickly was if we want to be able to assess data quality, if we want to know if the data are good enough to be used, we need to develop systematic approaches. So this was my roadmap to EHR data quality assessment. And my first step was to perform a more in-depth literature review. So what I want to find out is what is the state of the field? How are informaticians talking about and measuring electronic health record data quality? And this, if anyone's interested, has been published in JAMIA. So part of the problem with doing this kind of research, there are no mesh terms in PubMed for data quality. So we used a whole bunch of different search strings, went through the original batch of results, and then ended up doing an ancestor search to try and catch all of the stuff that we'd originally missed. And we ended up with a final pool of 95 relevant articles. And we wanted these to be original research, we wanted them to be peer-reviewed, and we wanted them to be talking about actual methods of data quality assessment. And from each of these articles, we pulled the dimensions of data quality that were being studied, the methods that were being used, and then we kind of aligned those 2 things with one another, and we went through them iteratively to try and identify some basic categories. So here you can see all of the different terms we used that were intended to describe data quality, and we grouped them into these 5 dimensions of completeness, concordance, correctness, currency, and plausibility. I'm going to go through those in a bit more detail. So completeness is the most commonly assessed dimension of data quality in the literature. And it's basically asking, is the truth about a patient present in the EHR? One point that I want to make is when you're talking about completeness, often clinicians will describe this as, was something that was observed recorded? When you talk to researchers, they're just asking, is this thing that I want in the data? Can I get this? They don't care if it was observed in the first place because that's not what's interesting to them. They just want to know if they have it and if they can use it. Correctness is an element that is present in the EHR true. Currency is an element in the EHR, a relevant representation of the patient's state at a given point in time, because a lot of clinical phenomena will change over time. Concordance is there agreement between or within elements in the EHR, or between or within elements in the EHR and another data source. So if you have potentially the same variable at 2 different times, are they in agreement with each other? If you have 2 different variables, maybe you have a lab test and a diagnosis, do those agree with one another? And lastly, plausibility. Does an element in the EHR make sense in light of other knowledge about what that element is measuring? So this is kind of a bit of a face validity dimension. I also extracted 7 approaches to data quality assessment. The most common was the use of a gold standard or reference standard, which is when you take another data source or you combine data sources to create your reference standard and you use it as your source of truth. One problem with this is often you don't have a gold standard available, so the fact that this is the most common method is really pretty problematic. Also, what people call a gold standard often is not actually a gold standard. Next was data element agreement. So this was used a lot to measure that dimension of concordance. Are 2 things in the database in agreement with each other? Element presence, usually used for completeness. Is this thing I want actually available? Data source agreement might be when you look to see if your EHR data agree with something in a registry or paper documents that are kept concurrently, but there's no assumption that one is more accurate than the other. You're just trying to compare them. Distribution comparison is when you take a distribution or a summary of aggregated data and you compare it to what you might see as an expected distribution. So you have your patients, then you have registry data for totally different patients, and you just look at those distributions and you see if they align with one another. If they don't, do you have a good reason for it or not? Validity check, very simple, might be something like you have a range limit on blood pressure or heart rate. If your data value exceeds or is below that, you may have a data quality problem. And lastly, log review, which is usually used for currency. And it's when we look to see if the information, the metadata attached to the data of interest can tell us anything about the quality of the data. So this takes those 95 original articles and it maps each of those dimensions of data quality from most common to least common to the methods of assessment from most common to least common. And again, you see gold standard up at the top. That's very common for completeness and correctness. You've got some where you have almost a one-to-one relationship, currency and log review. That's essentially the only time you'll see those 2 things. So what we really got out of this at the end is still this idea that data quality assessment is ad hoc. It's not systematic. It's overly reliant on things like gold standards. And these were problems we were going to have to address going forward. So this was our first step in our roadmap to data quality assessment, and from that we got the set of dimensions of data quality, these methods of assessment, and the fact that we need a systematic approach. So for the next step, we wanted to come back to this fact that actual data quality findings are so incredibly variable. And we know part of that is because of differences in which variables we're interested in, though again I want to point out that Chanadol result where for blood pressure there's still so much variability. It could be partially institutional. It could depend on the culture of clinical care that you're looking at. But our suspicion was the fact that we have this variability in what methods are being used and how we are operationalizing data quality concepts is itself causing a lot of the variability in findings. And this brings us to a common definition of quality. So Duran originally proposed this idea of fitness for use. Quality is fitness for use. And that's not just data quality, but any kind of quality. And Redmond took it a step further, specifically for data quality, and said, data are of high quality if they are fit for their intended uses and operations, decision-making, and planning. Data are fit for use if they are free of defects and possess desired features. So what this might suggest is that depending upon what your study is, what you want out of that data, you're going to have a different idea of data quality, and that's going to give you different findings, even for the same data set. So in our second study, we wanted to answer this question, is data quality task dependent? How do definitions and operationalizations of data quality affect data quality findings? And this was published in JBI. So I mentioned this briefly, but I wanted to talk about how we are defining completeness again. So data can disappear or go missing because they are either observed or unobserved originally. And then those observed data are either recorded or unrecorded. So you've got 2 points where the incompleteness can take place. And again, I want to point out we can't just stick to the clinician-based description of completeness. That is, anything that's observed should be recorded. It could be you want data that weren't observed in the first place. So this is a very simple way of conceptualizing the patient record in the EHR. We have a whole bunch of data types. It's a longitudinal patient record, so everything's recorded at these different points in time. And we have this for every single patient. So using that basic conceptualization of a patient record, I just want to give 4 possible definitions of completeness. So here's the clinician definition, documentation completeness, where all of these observations are inside that record. They're all inside that box. So everything that was observed was recorded. This is very hard to measure without a gold standard, so we had to find some tricks to get around that. Another possible way of defining completeness is that you have a breadth of data. A record is complete when it contains all the desired or expected types of data. Orthogonal to that, density completeness. A record is complete when it contains a specified frequency of data points over time. And lastly, predictive completeness. A record is complete when it contains sufficient information to predict a clinical phenomenon of interest. So here we don't have any specific data requirements. There's nothing explicit, but we want to be able to predict that red point off in the future. You could have 2 very different records that both let you predict what you're interested in. They're both complete according to this definition. And this is something that might be more relevant for someone who's doing data mining or predictive modeling. So for this, we used all of the data in the Columbia University Clinical Data Warehouse. At this time, it was approximately 3.9 million unique patient records. We didn't use every type of data for each patient. We kind of operationalized each of these definitions using certain data types just to demonstrate an idea. This is our general population. And this is the overall finding. So these are the 4 different definitions of completeness overlaid. And again, this is going to change depending upon which variables you're looking at, because we weren't looking at all of them. But the fact remains that there's some overlap for some definitions, but there's a lot of places where you're not getting full overlap. I also want to touch on one thing quickly, which is you can see this, the second circle, the nested circle, which is patients who have at least 1 clinical data point, is I guess about 55%, which is interesting in and of itself. That is because we have a lot of patients who are in our master patient index, but they were seeing people who didn't have electronic health records, or they had records that were not dumping directly into the clinical data warehouse, which is a huge governance problem all on its own. And it's also the fact that this is historic data. If we were just limiting it to like the last 2 years, it would probably be much larger shapes. What I really want to emphasize is if you want the overlap of all 4 of these definitions, you've got fewer than 1% of our patients. So what we've really found is depending upon how you're defining what seems like a fairly simple data quality concept, what your specific research needs are, you're going to get very different results. So at this point, we've shown that data quality depends on your research task, and also that we're going to need a dynamic data quality assessment approach. You don't have a one-size-fits-all solution for all research. So anytime someone wants to conduct a study, if they want to decide if the research are good enough quality, the DQA methods are going to have to respond to their specific needs. So we did at this point, we had like kind of a little offshoot of this study that I want to go through very quickly, but we thought it was very interesting. We wanted to know who are these 0.6% who actually have a lot of data according to all 4 definitions. And our hypothesis is that sick patients have more data. I think this is what most people would assume. What's important about that is it means that if you are selecting based on the availability of data, you are selecting sicker patients. So you're automatically creating bias in your study. And we wanted to see if this is true or not, because it's something people assume, but it's kind of not really discussed that much. This was published in the AMIA proceedings of last year, and we also have a more complicated version of the same analysis that looks at more covariates that's under review right now. We're hoping for good reviews. So what we needed was a health status indicator, and I was working with an anesthesiologist on this project. So we used the ASA physical status scores, which range from 1 to 6, 1 being healthy, 6 being brain dead. We limited it to groups 1 through 4. And this is a big limitation in this study. It's a very specific type of sample, but it's one of the only physical status indicators that's not dependent upon the completeness of the data. So something like the Charleston Comorbidity Index, you can't actually calculate it for most of your patients because you don't have all the information you need. For completeness, we did simple counts of days with medication actions, so orders or stop giving this medication, and counts of days with laboratory results. We had 5,000 patients, and we only wanted people who had one anesthesia, one episode of anesthesia and nothing in the past year. And we looked at the counts of data in the preceding year. We used a Kruskal-Wallis one-way analysis of variance, which is a non-parametric test. And this is the original distribution of patients across these ASA bins. You can see why we used a non-parametric test. They're very uneven sample sizes. And we found what we expected. So over here you've got the amount of data across ASA scores for medication orders and for laboratory results. And there's a significant difference between all of these except groups 1 to 2. So as we expected, sick patients do have more data. And here, just so that you can see why this really might matter if you're doing a study, this is, again, the distribution of patients over ASA scores if you have no threshold for how much data you need. This is if you need 10 points. And you can see this distribution is very much skewed in a different direction. That second population is going to be a lot sicker than the first one. So this is interesting because you can see that data quality is actually going to co-vary with patient health in some circumstances, which is problematic. So going back to that roadmap to data quality assessment, our next step was that we wanted to actually talk to the consumers of these data. So we wanted to understand the perceptions and needs of clinical researchers who might be interested in reusing these data. And this is work that the data analysis is all done. We're working on a manuscript right now. So we had a couple of questions going into this. What are researcher perceptions of EHR data quality? Are these perceptions a barrier to reuse? And lastly, how do researchers currently handle data quality problems? Because we are interested in perceptions and how those perceptions might change behaviors, we use the precede-proceed model to inform this research. This is usually used for modeling health behaviors, but it can be extended nicely for this kind of situation. And we were focusing specifically on this section right here, predisposing factors, enabling factors, and reinforcing factors. So a predisposing factor is something that makes you more or less inclined to engage in a behavior. An enabling factor is something that makes it easier or harder to engage in that behavior. And a reinforcing factor is something that rewards or punishes you for engaging in that behavior. And here, the final outcome, the final behavior of interest would be the increased efficiency of clinical research, and the intermediary one is reuse of EHR data. So we developed an interview guide. We didn't want to just straight up ask, what are your reinforcing factors? What are your enabling factors? So instead, we asked clinical researchers about their actual experiences using EHR data, their attitudes towards those data, and their intentions to use those data in the future. And I know there's kind of a wall of text here, and I don't want to spend too long on it. I interviewed 10 clinical researchers. We used purposive sampling because we specifically wanted to identify people who would be targets of this kind of data quality assessment intervention. And they were all researchers within the CUMC community. We used a combined inductive and deductive approach. So the inductive approach would be the fact that we applied this phase 3 of the precede-proceed model. We had a theoretical basis going in. But within those major categories of different kinds of factors, we derived themes, and that aspect was deductive. So I'm actually going to start from the bottom. I'm going to start with the reinforcing factors and work my way up because it goes from the simplest to the most complicated. So as you would expect, The reinforcing factors to reusing EHR data are its facilitation of research. So the EHR data facilitates a tremendous amount of research that wouldn't be possible otherwise without exhaustive review or manual processing. And facilitation of publication. The New York Presbyterian database could be a paper-generating monster. A good monster. So the enabling factors, things like availability and accessibility of data, the fact that it can be very difficult to identify relevant data or relevant cohorts, and lastly, the skills to actually reuse those data. And a lot of these clinical researchers would get these big dumps of data and they had no idea what to do with them. I'm not going to go through all of these, but I just thought, I know anyone who's used the discovery process with getting these data will identify with this. That's a big barrier here. I mean, you can wait a long time to get results because there's really just two people writing programs to pull stuff out. It's not actually the case. I know it seems like that to people who want the data. I had someone talking about throwing a request over a wall, and you never know what's going to come back out. And then the predisposing factors were where really the meat of the results were, and this was the interesting part. And they fell into a number of categories. Pre-existing knowledge of data quality problems, beliefs about the factors that are impacting the data quality within the EHR, beliefs about the EHR data quality, beliefs about other people's attitudes towards EHR data, because some of the researchers said, well, you know, I know this is true, but I think these other clinicians, these other researchers don't have the same awareness I do. Beliefs about requirements for reuse, what you should be doing if you're using the data. And lastly, their overall attitudes towards reuse. So in terms of knowledge of DEQ problems, data quality problems, we got another set of data quality dimensions to go along with those literature review results. Some of them are the same. So completeness, correctness, fragmentation is the fact that often they would want some data that was in 2 or more different places within the EHR. Concordance, again, they saw non-structured data as being a data quality problem when it came to reuse. So anything that was in a free text field or free entry field. Granularity, often you might have a diagnosis that you're interested in, but it's not going to have enough information. So maybe you're interested in pancreatic cancer and you can find that diagnosis, but you want to know where in the pancreas that cancer actually is, and that's not as likely to be present. And lastly, signal to noise. There's a tremendous amount of data. Most of it's irrelevant. So how do you find the parts that are relevant and pull them out? And how do you know what's safe to discard? In terms of beliefs about factors impacting data quality, there are some thoughts on the traits of the data themselves, so sometimes manual versus automatically recorded data, or optional versus required data. System features were a big one. A lot of people felt that the EHR itself was responsible for the generation of poor quality data. And lastly, user behaviors. So is a clinician in a big rush, or are they just clicking on that first option, that default value, so that they can get on with what they're trying to do? One common example is nobody wants to use the indication for a radiology exam because everyone just goes into the pull down, clicks the first thing, shoots off the request. You never, ever use that data. In terms of beliefs about EHR data quality, it's legendary among trialists that what's in a chart, the kind of rules about what you put in there, who puts it in, and how careful they are and whatnot is pretty sloppy. So they were saying this in contrast to a clinical trial where you have this huge book that tells you exactly how you're collecting everything, what you're collecting. You're probably doing double entry for at least some of it. So some pretty negative views on EHR data quality, or negative beliefs. In terms of beliefs about requirements for reuse, I thought this was very interesting because this can inform data quality assessment approaches. So a lot of people thought that there should be a space for the clinician to actually be involved in the assessment process, or at least the interpretation of the results. As clinicians, I think when you deal with all these types of situations, you understand the process by which this data is generated. And I think that's why it's important to have clinician involvement in this kind of research. So basically what they're saying is they don't want a black box process. They don't want a program where you toss in the data, you get some number, because they don't trust it. They want to actually look at the data and say, well, I have this clinical knowledge. I have this knowledge of the system. I know that I've recorded this. These are my concerns. So they want there to be a certain kind of subjectivity involved in the data quality assessment process. And lastly, the attitudes towards reuse. I'm not a huge fan yet, but I'm a believer. I think there are a lot of opportunities there. And I saw a lot of that. It's conflicted. And then the second one, I think, though, is very important. It's not even a question of positive or negative, because I think it's the way of the future or the way of the present. So regardless of the problems with the data, even if we find overwhelming data quality issues, people are going to use these data because the opportunities that they have are really tremendous. So it's not just something where we can say, don't do this. We don't think it's a good idea. We need to find the best ways to enable this reuse. So from this step, what we found was another set of dimensions of data quality, the fact that reuse is going to occur despite any concerns about data quality that might exist, and the fact that there is some kind of clinician involvement desired in the data quality assessment process. So the next step, which is what I'm currently working on, is the development of data quality assessment guidelines, bringing in all of the knowledge that we learned from these previous studies. So as a quick recap, what do we know at this point? We know that EHR data will occur regardless of data quality problems. We know that we need systematic, evidence-based data quality assessment approaches instead of the ad hoc approaches that have been largely used in informatics so far. We know that we need a flexible and dynamic approach to data quality assessment to handle the different data quality needs, this concept of fitness for use. And we know that it would be ideal, at least from the researcher perspective, to have some kind of clinician involvement in data quality assessment. So the last step, which is currently underway, is the development of these data quality assessment guidelines. I'm just about done with the first draft of these. The next step is going to be evaluation, and then further iteration on the development. So from the dimensions of data quality I identified in the literature review and the interviews with clinical researchers, we identified these three core kind of atomic dimensions of data quality. Data that are of good quality are complete, correct, and current. And I just wanted to remind you of this simple conceptualization of patient data in the electronic health record. You can kind of see that there are three dimensions of the data. We've got patients, variables, and time. And what we did was we created this 3x3 framework. And to kind of go along with this idea of fitness for use of dynamic data quality assessment, we know that different studies are going to have different requirements. They're going to have different data. Some of them will be longitudinal. Some of them won't be. They may have different numbers of variables. You may have something where someone is just doing a very simple case review versus having a large number of patients. So depending upon those studies, you're going to have different kinds of data that are involved. You're going to have different kinds of assessment methods that you can actually employ for each of those dimensions of data quality. And these methods, which fill in the 9 cells inside, are largely pulled from that original literature review and then pulled from some other literature on data quality from outside the informatics world. There's a lot here. I don't want you guys to read all of it, but I'm going to end up taking you through one specific example. For now, I want to show you where this framework fits in the overall data quality assessment guidelines. So in order to determine which of these assessment methods are actually relevant, the first step is that there are a series of questions to identify the scope of your study. So it's going to be questions about your data needs and your data quality needs. After you answer all of those questions, you're going to have some subset of these 9 items that are going to be relevant for your study, relevant data quality assessment actions, and those in turn map to assessment and reporting recommendations. So these are examples of some of the questions to identify scope. So depending upon how you answered earlier questions, and I believe there are 13 or 14 questions total, and you don't answer all of them, so it's a pretty quick process. It should take only about 5 or 10 minutes. So questions like, do you have a specific time frame or frames of interest? For example, do you have a range of dates or a specific season that you're interested in? And then you have an answer sheet where you can mark down what your response is. Do you require or expect that different variables should be recorded in a certain order relative to one another? Depending upon what your answers are to all these questions, you're going to have different kinds of assessment methods that you're going to want to do. So this is the one specific example I'm going to take you through. So say you answer all these questions, and it says you should do, subset whatever of these 9 items, and one of them is 1B. 1B is the intersection of correctness across variables, correctness across patients. So the distribution of values is plausible across patients. And this is kind of derived from one of the methods that I identified in the literature review. And again, one of the things that I wanted to do was stay away from gold standard reliance. So you're not going to see any methods here that say, you've got your source of truth, see how many of your items are correct. So we're kind of getting the closest proxy to accuracy that we can. So this is one approach. You have multiple patients. You want to assess correctness. Is this distribution of values plausible across patients? And you can do this for certain types of variables. This is what the recommendation would actually look like. And there are actually 2 different approaches for the specific one. I'm giving the second. And part of the goal here was to make it very readable, to make it something that was easy to look at, easy to parse and interpret. And each of these recommendations includes the measure that you can actually do, so the method, what you would report, and then it gives a very brief example, just if it's difficult to conceptualize what it's suggesting. So for this one, the measure actually talks about identifying an external source of data on the same concept you're interested in, and taking that distribution and you compare it either statistically or visually to the distribution of that variable within your own data set. You report whether there is alignment or misalignment between those data sources, how those distributions would actually differ, and whether there are possible confounders. So a confounder in this situation might be, well, I know the population for that registry is very different from mine. If you don't have some kind of confounder like that, you might have to assume that there might be systematic bias, for example. This is a simple example, just so people can actually see what it means to take 2 distributions and compare them against one another. And then there are references. So if someone wants to delve a little more deeper into this idea, they can pull up these pre-existing papers or books that use this approach, and they can see it operationalized in a little bit more detail. So we're going to be using an iterative design approach. The first round is going to involve sending this out to a set of experts, and what we're doing right now is actually working on developing a criteria for who is an expert. We've developed a fairly extensive evaluation instrument that is looking at validity, comprehensiveness, clarity, and ease of use. And then we're going to do a round of redesign. So what's next after that evaluation, after that iterative design? So I'm involved in 2 projects that are looking at data quality assessment. I'm working with a really great group of people led primarily by Michael Kahn out of Colorado. So for the EDM Forum, we have a smaller project which is working on the development of a comprehensive framework for data quality assessment and comparative effectiveness research. And this is going to involve interfacing with a lot of different experts, not just in informatics or healthcare, but data quality more broadly. Coming to an agreed upon framework, seeking feedback on that, and the publication of a series of white papers. So the hope is to really kind of get that out there into the CER community, get everyone on the same page. And then for the PCORI grant, we're working on building patient-centered outcomes research value and integrity with data quality and transparency standards. So this EDM project kind of falls nicely into that PCORI grant, where it's going to be the first step is developing this unified framework of data quality assessment, but then it's going to take it several steps further into actually operationalizing that model, developing software packages that can be applied to data sets, actually testing it out on a number of data sets, including OMOP, And then also taking it a step further and developing real reporting standards, so things that could go into a quote-unquote Table 1 in any paper that is published using EHR data. And then more personally, something that I'm interested in, you may have noticed that when I talk about EHR data, I talk about everything after the whole data life cycle. So you come over here, you pull the data out, you've got your data set. What do you do with it then? So at that point, there's not as much room to actually improve data quality. The data are what they are, and there are certain techniques you can use, but it's a static data set at that point. But EHR data is actually kind of a living creature, and it's collected iteratively in this data life cycle. So you may have points where the patient meets with the clinician. You have times when laboratory and medication data are getting dumped in. You have points where administrative services are going through those data and generating new data. You potentially have points where patients are interfacing with their data directly, either through a PHR or possibly in certain medical offices, you actually are given access to your data on a tablet. So there's the possibility for change in generation there. And what I'm interested in is finding those points in the data lifecycle where we can actually improve data quality or check data quality. And the trick is going to be finding times where the interests of those different stakeholders, the clinicians, the patients, the administrators, are in alignment with the desire to improve data quality, because you don't want to just keep adding more burden. You don't want to say, document more carefully. We're certainly not going to do double data entry. So perhaps medication reconciliation would be an opportunity for that, where there is an interest from the clinician and the patient in really getting good data there. What can we do to help enable that process? So that's what I'm beginning to look at right now. And I wanted to thank all of my committee members and my funders. And if you have any questions, I would be happy to take them.
Hold it down. Just like one example, I think the ICD-9 has like 0 references to periodontal, and the ICD-10 has a bunch of them. Mm-hmm. So now it's possible to be able to track babies born with mothers who have that condition. And so at 1 month, did you see this? 6 months, 1 year, 2, but they have to record it first. So is just for one example, is there some awareness that in ICD-10 now there's a whole bunch more stuff that can be noted and tracked, and how can you get that to be recorded?
You mean how can you get people to switch over to using the ICD-10 codes, or? Well,
yeah, now there's that much more things that can be quantified. Mm-hmm. Is there now a greater awareness that that can be done and it should be done, et cetera?
I don't know. I mean, there are a lot of places where the whole issue of standards and vocabularies is going to interface with data quality, partially because everyone's using different standards. I think even if people know that there are data that they can record, this issue of completeness is difficult because people aren't going to record things that aren't relevant to the specific clinical issue that you are interested in. So yes, it's great if there are more things that we can quantify. Does that mean that they are going to be quantified? I don't know. Is that answering your question?
The point that you can look at more things now, potentially.
Yeah. Yeah, I mean, the amount of things that we have data on is just going to continue to expand. And we are going to have more and more different kinds of sources of data. There may be more automated data that's recording things with greater frequency. There's just going to be more of this, hopefully. Whether that actually means any improvements in data quality or just more data with quality problems, that's hard to say.
Yeah, great talk, and it's an area of interest to a lot of us. As I was listening, I was thinking about there's sort of another wrinkle to this, and I'd be curious in your thoughts and how it fits into your model. You alluded to it at a couple points, but one thing that we'll be seeing as time goes on is transforming of data. the sort of prototype example being like NLP processing of a text note, but and there may be other ways, for example, genomics data as it kind of comes down the pike and we learn new things about genomic variants that, may or may not be represented in the chart. So how do you, I guess, does your model account for the fact that data isn't necessarily just static? It's being transformed along the way, either when it's generated or down the road. How does your model account for that?
I would say that's one of the pretty major limitations of this, that it is assuming that you've got your data set and it is what it is. I think the model and the applications that are going to be developed as part of the Corey approach are going to hopefully be more robust, and they will be able to deal with that fact that the data are changing. Some of the methods, I think, could be applied to different kinds of data, different modalities of data, instead of just the strict clinical structured information. There's no reason you couldn't extract information using NLP and apply these same methods. Something like genomic data would take a different kind of knowledge base that I'm not nearly as familiar with. So I'm sure there are kind of parallel methods that you could be using.
So you mostly talked about this in terms of clinical research, but it seems like there's a lot of similar issues in terms of using this data for clinical quality measures, which aren't typically considered secondary use, but are from a certain point of view. So how do you think your work applies in that domain?
I think there's probably a lot of overlap. The caveat with that is I did try to really target this to researcher needs. So I think it would be interesting to sit down with people who are involved with quality metrics, quality of care, and talk to them about what their needs are, how they're using the data, what their concerns are, and see if maybe this approach would align with what they're trying to do. I would hope that there's a fair amount of overlap.
So very interested in this from, I think, related to Aaron's question. So we think a lot about stakeholder incentives and willingness to improve data as we're trying to improve clinical quality measures, right? And so we think about the whole life cycle of the data when we do that. But we don't have a good way to document our assessments, especially where they vary in terms of data quality by the source and how far we've gotten with this. And I was sort of wondering if you could reflect on, you're talking about researcher needs, and as you're pulling data and assessing its quality, and you're going to report it, which is a lovely thing to do. But what about in the source of the data, the sort of metadata about this data and its quality? Could some of this be applied there, and if so, how? If not, what would we need to extend?
Yeah. A lot of people are very interested in the idea of metadata, like you said. Some of the researchers who I spoke to wanted to have that attached to everything. So it's not just who's recording it, where it's being recorded, those basic concepts. But what they wanted was if someone had sat down and done chart review for 100 patients, they wanted that to be noted somewhere. Or they at least wanted that final data set to have that information attached to it so someone didn't feel like they had to do that work over again. There's certainly the potential for the metadata itself to be much larger than the data that you are actually using. I think there's a potential for a little bit of trouble if you are talking about something like fitness for use, where someone might do an assessment and then you attach that assessment result to the data, and someone wants to use it for something else. You don't know if that result is still going to hold. But I do think that there's certain kinds of information that are still helpful. So one thing I mentioned very briefly was the fact that the different traits of the data might be able to impact data quality. So was this required or optional for input? Was it automatic or manual recording? So those types of information might be proxies for data quality. So adding that in could give helpful information.
Nicole, I had a question probably similar to Bill's and Aaron's, that one of the things that's a little bit overwhelming about the EHR is that there's so much data that's in it. And I think I guess it's a two-part question. One is that in part two, you talked about sort of data completeness through this big clinical data repository. Mm-hmm. And so the question is, what kind of data was it? Because it looked like it was kind of lab data and exam finding data. And I guess the second question is, in terms of using these data for sort of secondary purposes, what do you see as the most promising types of data? I guess I'm thinking problem lists, diagnoses, things like that. And so what's your thought about those?
So for your first question, the kinds of data we used, I didn't want to put up too much text. It was mostly medication orders, laboratory orders, the presence or absence of clinical documentation, so a note, but not the actual data in the note, basic demographic information. So we tried to choose things that were kind of representative data types. But yeah, the array of different things we could have looked at is close to unlimited in a lot of ways. So can you tell me your second question once more?
Sort of potential for, well, actually, let me re-ask a second question. Sort of that wasn't my original second question. Mm-hmm. But with the lab stuff, because I think that what I'm thinking of is in terms of if a doctor types something into the EHR or just clicks the button, did they click the right button? Mm-hmm. And do you think the findings that you're seeing in terms of the lab data and the medication orders would generalize to, did the doctor click the right button, or did they put the right diagnosis or categorize it correctly? And because I think that's the other aspect of data completeness.
Mm-hmm. So if the assumptions that you might make about the recording practices of those data would hold true for other kinds. I think it's going to really depend on the system that you're using, how intelligent the EHR is, how difficult it makes to input the kind of data you're interested in. We use those because they're kind of the most commonly requested types of data. But, I mean, if you're getting into more complicated data, so maybe data that's been abstracted out of radiology, something like that, yeah, those processes that are behind it are very different. So I think the methods could probably be extended, but the findings, the expectations of the quality, I don't know about that so much.
I think that there are several people here who are interested in things like quality reporting and exactly this type of stuff. And I think there'd be a lot of potential for stuff that what you're interested in.
I guess the bottom line is don't let the, what is it, the old saying, don't let perfect be the enemy of good.
Just a quick one. We had a PhD student who graduated last year who was kind of combining neuroscience with informatics. Mm-hmm. And one of the things he talked about a lot was in the neuroscience world, they also have that terminology problem where a lot of scientists use different terms for the same thing, same cell types, all that sort of thing. And I was wondering if you had encountered that because your background is related to neuroscience, right. and whether you thought their solutions, which were to kind of build alliances or consortiums to agree on terminology, if you think that's going to be something of a solution for what you were talking about early in your talk, where you were talking about that problem.
Right. I wouldn't say that's something that I personally ran into when I was doing the neuroscience research. We were kind of in such like a very specific area that I think everyone in that area was pretty much using the same terminology. I guess if we'd gotten into the broader biological issues, then that may have been something that I ran into more. In terms of trying to create consortiums and come to an agreed upon terminology, that's really what I'm trying to do, working with Michael Kahn and Meredith Nam and all of these other people who are on that PCORI grant, is the idea to hopefully get this unified model of data quality that is well accepted by the informatics or clinical community and hopefully disseminate it. Because that's the problem. People keep coming up with standards, and then instead of accepting the standard, someone else comes up with a different one. So that's the goal here. We'll have to see how successful we are with it. you. No tweets? No one was really excited about data quality?
Might be out there listening in.
I can't imagine George on Twitter.
No?
Maybe. I mean, could be wrong.